level 4 when there is no metastasis at level 1, 2, 3. So that means there have been a skip of metastasis in that case. And this was originally told in a paper in 1997, very old paper by Byers. And based on that, many clinicians even today they try to treat level 4, I mean neck dissection till level 4 for all the patients, but that is not the case. We'll see that. Then can level 2 dissection be avoided? Friends, we saw that there can be some detriment to arm function because of damage to spinal accessory nerve. So can level 2B dissection be avoided? That was another question asked. Third question was, is it needed to go so below in the supraclavicular region? Like, should we remove the level 5 node? So that was another question regarding extent of the neck dissection. So we are going way back in time. In 1990, this study by Jatin Shah, this was a very retrospective study. It was a retrospective study that showed that what they did was, at that point of time, only radical neck dissection was standard of care. I mean, reduced neck dissection were not done, but they tried to evaluate the patterns of neck dissection by examining their data retrospectively, and they found out that metastasis was found in 34% of elective neck dissection cases, the cases that were N0 clinically, and they electively dissected those necks, and they found that 34% of the patients they had neck node metastasis. But now come, let us see the pattern. In level 4, they found only 3% of metastasis. In tongue, RMT, and cheek region, there was no metastasis at level 5. And level 5 was involved only 1% of floor of mouth and gum primaries. So that is why, because there is no metastasis or very less metastasis at level 4 and level 5, okay, that these points they become the basis for the reduced extent of neck dissection. And further studies were pointed towards these points, that if this Memorial Sloan Kettering study is showing such a less chances of metastasis into the lower level nodes, so can we avoid dissecting those nodes? So this is the landmark trial by Tata again. The study was led by Gauri Pantavaidya, and you see they did a very nice randomized control trial, and it was a prospective study, friends. They evaluated 583 patients, and they divided the nodes in separate levels, and they evaluated the patterns of metastasis. So now let us see their results. They found out that most of the oral cavity cancers they had metastasis in level 1 to 3. Okay, level 1, level 2 and 3, like supraomohyoid neck was carrying most of the metastasis, and other levels were involved like less than 5%. So they said that 96% of metastasis happens at level 1 to level 4. So if you treat that much, level 1 to level 4, that is extended supraomohyoid neck dissection, friends, you will cover most of the nodal metastasis in N0 cases that can happen. Coming to skip metastasis, they did find some skip metastasis, but at level 3 and mostly in tongue cancers. Okay, so there was no skip metastasis at level 4 and 5 in the absence of level 1 to 3. Okay, so whenever there are positive nodes at level 2, level 3, then you can find a node at level 4, but else otherwise you won't find a skip metastasis at lower level node. Now coming to the factors that predicted level 5 metastasis and factors that predicted level 2B metastasis, because these were the questions we asked earlier, that do we want to treat level 2B, do we want to treat level 5? And if you see the results, whenever there was 2A positivity or level 3 positivity, okay, it showed level 5 metastasis present. Okay, and whenever there was level 2A positivity, that also showed that 2B was positive. So by this point, you can think that whenever there is a, like, there is no need to do a modified neck dissection, no need